The following podcast is part of a certified educational activity titled On the Cusp of Change, Modernizing the Treatment of Desmoid Tumors with Novel Gamma Secretase Inhibitors. Access the entire activity and complete the post-test at peerview.com/JST860. Downloadable slides and practice aids are also available.
I would like to welcome you all to this educational peer review event on the cusp of change, modernizing the treatment of desmoid tumors with novel gamma secretase inhibitors. And of course, it's my pleasure to introduce today's faculty. So my name is Bernd Kasper. I'm medical oncologist based in Mannheim, University of Heidelberg, Germany. And it's my pleasure to have my two speakers here on stage, Myrnal Gounder, medical oncologist from the Memorial Sloan Kettering Cancer Center in New York, and Alessandro Gronchi, surgical oncologist, head of the Department of Surgery at the Istituto Nazionale dei Tumori in Milan, Italy. We also partnered for this event with the Desmoid Tumor Research Foundation. The mission of the DTRF is to fund research to accelerate the development of improved therapies and ultimately find a cure for desmoid tumor patients. The DTRF collaborates with dedicated researchers around the world and clinicians to improve the lives of patients throughout education, awareness, and support. And here are just a few examples of all the projects they are involved in and they have already set up. So this is the agenda for today's 1 hour meeting. We will actually do a kind of review of the latest evidence in desmoid tumors. The first talk will be from Alessandro Gronchi, navigating the complexities of diagnosing and treating desmoid tumor patients, developing standardized workflows to implement a team-based care, which is important in this disease. And the second presentation is from Myrnal Gounder, examining the shift underway in the treatment of desmoid tumors, the promise of the novel gamma secretase inhibitors in this disease. We will then have a short Q&A session and some discussions point we can discuss together and a conclusion at the end. So let's get started with the first talk, and it's my pleasure to introduce Alex. The stage is yours.
So thank you very much, and thanks for having me here with you tonight. Yeah, so the incidence of this disease is pretty rare. So we have 2 to 4 new cases per million per inhabitants per year, which in Canada here would mean 140 patients per year. In the United States, 1,000 patients per year. In Europe, 3,000 patients per year, because Europe is small but pretty crowded actually. And yeah, so we don't have a lot of space like here. Now, the thing is, even if it is rare, the prevalence is high because patients don't die of this disease. The majority of patients are affected by a sporadic form of desmoid tumor, so it's not inherited. There's no genetic predisposition, but 5 to 10% of them develop desmoid fibromatosis in the context of FIP. Familial adenomatous polyposis, the Gardner syndrome. In either form, the sporadic one or the familiar one, recognize a predisposition, molecularly characterized by an alteration of the WNT pathway, either through a mutation of the beta-catenin gene or through the mutation of the APC gene. The beta-catenin gene is mutated in the sporadic form, while the APC gene is mutated predominantly in the familiar form. There is a female predominance. All sites can be affected, so basically it can occur anywhere in the body. Although the most common sites are the scapular girdle, the abdominal wall, and the lower extremity, while the threatening sites are the head and neck and the intra-abdominal one that occur more rarely, but they still can happen. They can be multifocal. This typically occur when they are multifocal. In the sporadic variants, they affect one limb. They can occur in the foot, leg, thigh, pelvic girdle, or hand, forearm, arm, and scapular girdle. This doesn't mean that this situation resemble the metastatic spread of other diseases. This is just a multifocal appearance of a single disease. Surgery is no longer the primary and only curative treatment of the localized disease. And so it was very well also clear before this talk. Unnecessary surgeries are harmful and should not be given. We have put together in the past years a consensus guidelines for the treatment of this disease, and has been very clear that the frontline approach to this disease should be active surveillance. Active surveillance, why? Why? Because survival is virtually unaffected, so we know that these patients may have recurrences or progressions, but survival is virtually unaffected unless the disease occurs in threatening sites, but this is very rarely the case, while quality of life is. So if surgery is performed, quality of life may be very much affected and may be more affected than what the disease can do by itself. Not to mention when surgery is combined with radiotherapy, and when surgery is combined with radiotherapy, also there's the long-term threat of radiation-induced sarcoma, like in this case. The spontaneous growth arrest of this disease, which beside the understanding of the lack of impact on survival, was one of the reasons why we started considering active surveillance as the first approach, was initially described by the Memorial Group back in the 90s through the publication of some case reports. Later, retrospective series from Milan and Paris was put together and to show that this spontaneous growth arrest was not just sporadic, was not just occasional, but was something that was occurring in as many as 50% of the patients. This was reproduced in multiple series and large over the last years, showing that the initial observation was no worse than primary surgery in terms of local control and disease control. Another evidence demonstration that the disease, that active surveillance is worthy, was the placebo arm of the first randomized study in the disease, the sorafenib study, because in the placebo arm it was clearly shown that patients were experiencing spontaneous growth arrest and also regression in some 20-30% of the cases. The same percentage of regression was then shown in an observational study performed in Italy and also in France and the Netherlands. This is the Italian study on 100 patients where there was a 25% initial spontaneous regression, which was also followed by some 30% spontaneous regression after initial progression. So in total, in these 108 patients, over 50% of the patients experienced spontaneous regression. This patient had a median of 37 years, and the median size was 4 centimeters with a median follow-up of some 35 months. The same occurred in the Dutch series, where there was a 30% cumulative incidence of treatment initiation, so 70% of the patients didn't need any treatment, and some 50% of them did experience regression even after initial progression. You see on the right side the spider plot showing how the single patient were behaving. And so I just show you here a case of a female of 40 years old which experienced a progression, and then after the progression started regressing over time. So this, in fact, happens in some 30% of the patients that experience progression. So when to consider active treatments, which is the most important decision to make today. So when you need to decide for an active treatment after having observed the patient. So in our treatment algorithm, we have divided patients according to the site of origin, and because there are different problems that are related to the site of origin and that need to deserve separate considerations. So, for example, when the disease occurs in the abdominal wall, surgery can still play a role. It can remain in the initial lines of treatment because it's usually followed by a very good local control. Other options include cryotherapy, other local regional treatments like cryotherapy, and now there are other modalities that can also be considered like HIFU or more recently even chemoembolization. While cytotoxic chemotherapy is usually considered medical therapy in general, and in the past, medical therapy was mostly cytotoxic chemotherapy, is usually considered for the disease arising from all other sites, namely the intra-abdominal, head and neck, or thoracic and extremity. Which medical therapy we did have in the past? Predominantly two types of medical therapies. One was the metronomic chemotherapy, the combination of low-dose methotrexate, vinblastine, or vinorelbine. And this combination was able to achieve a decent response rate, even if it was a slow process. So it was a treatment achieving a response on the long run, and a treatment which was usually given for at least a year, on average some 40 months, up to 2 years. And also patients who experienced progression after treatment discontinuation and who were a challenge were also achieving some form of response. So there are a number of studies on various chemotherapy regimens, but none of them is randomized. So all these studies show some kind of response in the 20-30% range, but none of them is randomized. Same apply to, for example, anthracycline, which is active in this disease, but it was never tested in a randomized fashion. More recently, tyrosine kinase inhibitors and sorafenib and pazopanib were tested. I'm not talking about nirogacestat, of course, because Marina will mention about this. We discuss about this, but tyrosine kinase inhibitors were studied, and the most important studies that was done in the past was, again, a study by Marina on sorafenib versus placebo, the first randomized study ever conducted in the disease, which showed a clear effect of sorafenib in the disease in terms of disease control and also disease response. As said before, even in the placebo arm, patients experience spontaneous growth arrest and regression in as many as 20-30%. You'll see later that Reynald will show the results of the placebo arm of the nirogacestat study, where this didn't occur so frequently, and this is possibly related to the fact that the inclusion criteria of the sorafenib study didn't include progression before study entry as an entry criteria, while the nirogacestat did. So this is a group of patients that had different type of diseases, from indolent to aggressive, and so in this situation, regression is more common than if you select only the more aggressive variants, which in fact don't regress quickly or in a reasonable time frame. This is instead the phase 2 randomized study comparing pazopanib versus low-dose chemotherapy, methotrexate and vinblastine, showing again, this was not intended to compare pazopanib against low-dose chemotherapy. This was just intended to have a kind of control arm, let's say, to using what was used at the time, low-dose chemotherapy. And also pazopanib showed a response rate which was similar to the one of sorafenib. This is in fact used in Europe, where sorafenib is not available, or at least in some of the European countries where sorafenib is not available. Pazopanib is the drug we use when needs be. So in summary, active surveillance should be the primary approach to sporadic desmoid tumors, as 50% of patients experience spontaneous regression in a median of time of 2 to 3 years. Whether this remains the primary approach, or whether the duration of active surveillance will remain the same in the year to come, is left to be understood, because the availability of drugs that have a higher effect as compared to the one we had in the past may change the treatment landscape, may change the duration of our initial active observation period. Extremity location and large tumor size, and also S45 beta-catenin mutation are strongly linked with and associated with worse outcome. We didn't discuss this in details, but this is what comes out from the observational studies that were published, and also something that will be discussed later in the meeting, at CITOS meeting this year. So on Saturday there will be a session dedicated to desmoid where these studies will be discussed. Extra care should be taken for head and neck and intra-abdominal locations, since progression may result in life-threatening symptoms. And this availability of new agents with high efficacy and limited adverse events may change, as I said, the treatment landscape of these tumors. But the bottom line will have to remain: first, do not harm. Very well. So over to you, Marina.
Okay, thanks very much. I'm very excited to be here and to be discussing the promise of the gamma secretase inhibitors in desmoid tumors. Gamma secretase inhibition in desmoid tumors. So this is a new class of drugs that most of us are not familiar with, and I think the oncological community as a whole will be talking about it and learning a lot more about this. But really the concept here is what are gamma secretase inhibitors and why do we think they may be working in desmoid tumors? So to understand that, we have to recognize that the vast majority of desmoid tumors have mutations in beta-catenin, almost 90%, and about 10% of them will have mutations in the APC gene. But the bottom line is both of these mutations, whether it's beta-catenin or APC, usually end up in constitutive signaling activation of the Wnt signaling pathway. And we heard about this from Alex before. We also know that there is significant crosstalk between the Wnt signaling pathway as well as the Notch signaling pathway. And we think both of these pathways contribute towards tumor growth. The concept here to understand is that for the Notch signaling pathway to activate, what you see here is on the surface on the plasma membrane, you have the uncleaved Notch receptor. There's a gamma secretase enzyme that needs to cleave this Notch pathway, and this cleaved pathway or this cleaved protein is known as the Notch intracellular domain. And this then goes on to activate HES1 and then has crosstalk with the Wnt signaling pathway. So the concept here is that by blocking the activation of this Notch signaling pathway through the gamma secretase inhibitor, two of them that we'll discuss here, we can potentially change the growth kinetics of this tumor. So today I will be discussing two studies that have been presented here. The first one will be the phase 3 study of nirogacestat, which is an investigational oral selective small molecule. And the second study will be a phase 2 study also of a potent gamma secretase inhibitor. So we'll start with the DeFi study first. So the key aspects of the DeFi study is that this is a phase 3 study. It's randomized in patients with progressive desmoid tumors. So as Alex mentioned before, even though we had the sorafenib randomized study, what was unique about the DeFi study is that patients had to have progressed by 20% in order to qualify to enter into this study. And those patients could be treatment naive or have failed other prior therapies as well. So patients were randomized in a 1:1 fashion to nirogacestat taken 150 milligrams twice daily in a continuous fashion, or randomized to placebo. And patients who progressed, radiographically progressed by 20% on the placebo arm, were then had the option to cross over into open label nirogacestat at 150 milligrams BID. So now let's look at the primary endpoint of this study was progression-free survival. The secondary endpoint was response rate, as well as patient-reported outcomes, which includes symptom burden, physical role function, and overall quality of life. This study was conducted in 142 patients who were randomized across 37 sites in North America as well as Europe. Looking at the patient demographics, we can say that both the nirogacestat, the treatment arm, versus the placebo arm were well balanced. And as you can see here, there were many patients who came into the study who had previously had failed other therapies. The median number of prior lines was 2 in both arms. Tumor locations were also well balanced between both arms. And here is the primary endpoint. So nirogacestat significantly reduced the risk of disease progression, and the study met its primary endpoint of improvement in progression-free survival. So what we see here is that the placebo had a median PFS of 15.1 months, while nirogacestat, the median PFS had not yet been reached. The difference in terms of the median progression-free survival was a hazard ratio of 0.29 that was statistically significant. And we see what's very impressive is that the progression-free benefit with nirogacestat was observed across all the pre-specified subgroups. But I want to highlight a couple of things. First, even patients with APC mutations benefited nicely. Patients who had failed prior chemotherapies benefited. Patients who had failed prior TKIs also benefited. So essentially, in all the subgroups, the PFS benefit was preserved. What about objective response rates? This is done by blinded independent central review, and we see an impressive 41% in the treatment arm of nirogacestat and 6% in the placebo. But I'd like to highlight that we saw complete responses of 7% with nirogacestat, while 0% in placebo. The median time to objective response for nirogacestat was 5.6 months and 11.1 months for placebo. So these are the waterfall plots for nirogacestat versus placebo. And as Alex mentioned before, there were also a few spontaneous responses that were seen in placebo arm as well. Next, we're going to look at the patient-reported outcomes. So this is the brief pain inventory short form, where it's based on worst pain intensity. The orange line is placebo, and nirogacestat is in the blue line. And as you can see, what goes down is an improvement in pain, and if the arrow is going up, that's a worsening of pain. And again, what we see here at the pre-specified endpoint of cycle 10, there is an improvement in the brief pain inventory in patients' pain in nirogacestat versus placebo, where the pain worsens. So this is a patient-reported outcomes that is specifically developed for desmoid tumors. This was co-developed by the Desmoid Tumor Research Foundation and Memorial Sloan Kettering. And what we see here is when we look at the total symptom scores of desmoid patients, we see that nirogacestat also has an improvement in the total symptom score compared to placebo, where these symptoms don't improve or actually worsen. And this is also statistically significant at the pre-specified time point of cycle 10. What about physical functioning impact score? Once again, there is also improvement with nirogacestat compared to placebo at cycle 10, which is also statistically significant. What about the safety profile of nirogacestat? So what we see here is that the most common adverse events with this drug, as we've seen with many other gamma secretase inhibitors that have been developed, are really the GI symptoms, such as diarrhea, nausea, fatigue, and also rash. The 95% of the treatment emergent adverse events were grade 1 or grade 2, although dose reductions due to these also happen in about 42% of patients, and 20% of patients discontinued due to these treatment emergent adverse events. And both these numbers are given for nirogacestat as well as placebo. One of the side effects that we saw on the DeFi study was ovarian dysfunction. And ovarian dysfunction on the treatment arm was essentially 27 of the 36 women who are of childbearing potential reported ovarian dysfunction. And so this was about 75% of the women reported ovarian dysfunction. But what's interesting is that 11 of those patients discontinued nirogacestat for any number of reasons, and all 100% of those patients had their ovarian dysfunction completely resolved. Of the 14 patients who remained on drug, 9 of those patients, or 64%, their ovarian dysfunction was resolved, while the remaining 36%, or 5 of those patients, still remain on the drug, and those symptoms are unresolved. So next, we're going to shift gears to another study. This is a seamless phase 2, phase 3 trial of a gamma secretase inhibitor, AL102, also for the treatment of desmoid tumors. And here also there are some subtle differences between the two studies, but this required a 10% growth in tumor dimension within 18 months, or desmoid tumor-related pain that's requiring non-opioid medication to be enrolled. And once again, treatment refractory or treatment naive patients were permitted. In this study, 3 different doses and schedules were evaluated. The first schedule is 1.2 milligrams of the drug given daily. The second schedule, 4 milligrams of the drug was given on 2 days on and 5 days off. And in third schedule, 2 milligrams were given 2 days on and 5 days off. And the phase 3, or the next portion of the study, is you pick a winner and then move on to a phase 3 double-blind placebo-controlled study against placebo, again with the option to cross over at the time of progression. So what did we see in this phase 2 study? So similar to many of the other desmoid studies, this has a median age of about 38.5 years. 74% of patients were female. Intra-abdominal tumors was 26%. And with many of the other therapies, many of these patients had previous surgeries, radiation, as well as therapies, including chemotherapy in 55% of patients, and targeted small molecule in 17% of patients. In terms of safety profile, this is consistent with many of the other gamma secretase inhibitors. Again, there are 3 different schedules and doses that were evaluated, but the takeaway message here is, once again, diarrhea, nausea, dry mouth, and fatigue, as well as amenorrhea, were all seen, including rash. And this is all very much consistent with the mechanism of actions of gamma secretase inhibitors. In terms of activity, what we see here is that the primary endpoint was actually a decrease in tumor volume, and that was met. As you can see here, significant number of patients had pretty rapid decrease in their tumor volume, regardless of which dose or which schedule you picked. And then the RECIST waterfall plot are also shown here. And what's interesting here is that we also see that there are T2 changes that reflect decrease in cellularity. So what does that mean? What we see here is that here is a patient with a active desmoid tumor that is cellular, which is bright in color. With the treatment of AL102, this changes its appearance and becomes dark, which signifies that the tumor is converting from a cellular active tumor to an inactive collagenous mass. And here's another example of a patient with an active cellular desmoid tumor that has essentially become completely collagenous by week 28. And this is the shrinkage, or basically the change in this T2 signal, or the shift towards collagenization that we see quite rapidly in 19 of the 21 patients by week 16, or really the first scan. So in essence, I would like to end by saying that although we think that the mechanism of action of gamma secretase inhibitors involves Notch and Wnt, it's far more complicated. There are dozens and dozens of gamma secretase inhibitors in the cells that do a various number of different functions. So as part of these studies, there are also tumor tissue that are being evaluated to understand the precise mechanism of action in this disease. Okay, Bernd.
Yeah, thank you very much, both of you, for these excellent presentations. And I think we can start with the Q&A session now. I already have a couple of questions coming in here, and the first question is related actually to the first presentation, and is on active surveillance. How do you actually determine when active surveillance strategy has failed? Maybe a question for you, Alex.
Yeah, in general, what we were recommending, even in the guidelines, was to monitor the patient for a minimum of 1 year and decide for an active treatment in case of absence of complications related to the tumor growth when 3 consecutive MRIs, 3 consecutive assessments were documenting a persistent progression. That was the way we agreed to decide when to start an active treatment. Is of course something that can change in the future. So it's not something that was written in stone. So it's the way we were used to consider the assessment of these patients and to decide when to start an active therapy. Why was so? The reason why it was so is because we saw repeatedly over the years that regression may follow progression. And if this happens, it usually it happens within the first year or so. So if the patients continue progressing after a year of observation, it's very unlikely that it's going to regress in a reasonable time frame. And so this means that you need to do something to switch the disease off. So basically what is the treatment intended to is to try to switch the disease off, something that may happen also by itself, but sometimes needs a help.
Yeah, thank you very much. The next question is also related to active surveillance, and especially the case when active surveillance fails. And we really, let's say, pose the indication for any kind of medical treatment. How do we actually select the type of systemic treatment? That means, when do we go for sorafenib? When do we go for chemotherapy, or maybe for the new class of gamma secretase inhibitors? At least what I can say from our experience is that usually has to do something with the dynamic of the disease. Alex already showed that in his slides, that if you have a really, let's say, rapidly growing, maybe even life-threatening desmoid tumor, which is luckily not often the case, but it can be the case, then of course chemotherapy would be the treatment of choice. And in other cases, we would probably go for tyrosine kinase inhibitors such as sorafenib, as in your study, Mirna. Or are you any other ideas for that?
Yeah, I mean, I think the bottom line I think of this is that this is not a easy decision. It's a complicated, nuanced decision that between the patient, taking the patient's perspective into consideration, the patient's life circumstances into consideration, as well as to balance that with the data that we have. So even when it comes to active surveillance, I think even that is a nuanced and complicated discussion. First, really relating to what is the size of the tumor, what is the location, and most importantly for me is, how symptomatic is this patient? And is active surveillance really appropriate for this patient even after fully counseling? There are some patients who are very comfortable with the wait and watch approach, while others fall into the wait and worry bin, and they're constantly worried about what's going to happen to them. So I think this is really sort of a complex and nuanced discussion that happens not just once, but perhaps when I meet with patients multiple times before they're comfortable with this idea of active surveillance. In terms of treatments and picking the right, or what would be the right drug, I think it's also important to recognize that there is no perfect answer here. I mean, it's again, what is the preference of the patient? What are the comorbidities that the patient has? For some, sorafenib is appropriate, but for some patients, if they have underlying hypertension or other comorbidities, it may be not the right drug. And for someone else, I tend to look at liposomal doxorubicin or methotrexate. It really depends what the patient is doing, where they are in their life, and other things. And I think as time goes forward, if any one of these gamma secretase inhibitors are approved, I think the conversation with the patient will still need to be a nuanced conversation. It still needs to be a detailed thing. So that's how I generally approach my patients.
I agree. I think the bottom line in general in the management of the disease should always be that you need to try to avoid to make the patient sicker or more symptomatic than what the disease does by itself. And this applies to the treatment you have. So why I say so? Because, I mean, you would wait long if the treatment you have do not come without side effects. And you need to weigh the side effects with the waiting and what the disease does during the waiting. So sometimes you just need to control the pain, and you don't have to give an active treatment, because in order to allow the patient to be able to wait long enough for the disease to shrink. Of course, when different treatments with a different safety profile and also a different activity profile come into play, this may change completely the duration of the observation, because of course every patient would like its tumor to go away sooner rather than later. So I would expect, if I had the magic stick, for example, that the patient wanted me to use it regardless of the fact that disease can go by itself. So if I have a drug that works better than the one I had in the past, and it comes with a better safety profile, that I can use it, well, of course, I may use it sooner rather than later, because every patient would want his lump to go away sooner rather than later. So I think it's indeed a nuanced discussion that needs to take into consideration the side effects, the question mark we have, because all the new drugs don't come without question marks on the long run. So if I treat a patient for a year, 2 years, 3 years with pazopanib, and the patient was all his life expectancy ahead of him or her, I don't know what's going to happen 10 years down the line. If it's a child, I don't know what's going to happen 10 years down the line, 15 years down the line. I know what happens with the chemotherapy, but I don't know what happens with these new drugs, let alone gamma secretase inhibitors that have been introduced in the clinic only 10 years ago. So all this is part of the discussion that we need to have, and this probably change in the future, in the immediate future, and even later on, when more data will be available.
I completely agree with you. Yeah.
Yeah, definitely. It's always a multi-dimensional decision which has to be taken with the patient.
Which will include also the availability now of more effective local regional treatments other than surgery. So cryotherapy is part of the discussion today, and IFU is part of the discussions, at least in some centers, and more also chemoembolization will become part of the discussion, because these are local regional treatment that can be used as an alternative to any medical therapy.
I have another quick question regarding TKIs. There is a question: if a patient has a good response but does not tolerate the TKI or the first TKI he or she is on, would you consider a different TKI or go to another therapy?
No, I would go to another therapy, whatever that other therapy is.
And what would be your preference? Or
I think you have to treat that unique patient in front of you. I don't think there is one answer.
Then I have two very quick questions regarding gamma secretase inhibitors. Have we any potential biomarkers predictive of the effectiveness of gamma secretase inhibitors?
I'm not aware of any particular biomarker to select
the short
patients.
answer is no.
No. The short answer is no, exactly. Yeah. Could ctDNA have a utility in monitoring the disease and treatment response?
I think ctDNAs have been shown to have, shedding, and they have been picked up in desmoid tumors. It's not something that has been universally adopted, but in research studies, we do see the ctDNA. But again, I think I'm not sure. I think a scan is probably far more effective, done probably every 4 to 6 months, to evaluate the efficacy rather than ctDNA. Unless we have some new or emerging data that shows that this is a better way to look at treatment response. For the moment, I would just stick with scans.
Yeah, and also symptoms control.
Symptoms, yeah.
Because the first demonstration of a response with all the treatment that we've been using over the years has always been the reduction of pain.
Yes.
pain reduction, improvement in function,
Yes.
and later, usually later, evidence of disease shrinkage is usually what happens. And if you use MRI, a change in T2 signal is usually a key to predict response in general.
Indeed.
Much more than circulating DNA
I agree.
so far.
Yeah, we just have to ask the patient how they're doing.
Yeah.
Yeah.
Okay, I would like to move to a number of discussion points we have put together, and I think we have learned, and Mirnal very nicely showed that of course there is a great promise regarding the novel gamma secretase inhibitors. DeFi represents a very large randomized control trial, maybe the largest we have so far conducted for desmoid tumors, with nirogacestat demonstrating impressive activity, and it will most likely become the first regulatory approved systemic therapy. Another gamma secretase inhibitor is on the way, AL102, also showing very promising activity. So this is definitely a step forward for our patients. That is important to say. So the first question or discussion point I would like to raise is, what would be your opinion? What a gamma secretase, will gamma secretase inhibitors become the standard of care in a selected, let's say, patient population? We tested them, of course, always in progressing or symptomatic desmoid tumor patients. And how can we integrate them into the current treatment strategy or paradigm? What are your opinions on that?
I mean, again, I think there is no one right answer for all patients. I mean, I think it's truly it has to be personalized for an individual patient. And if it turns out that and as Alex very rightly said, you really need to make sure that whatever treatment you're offering the patient, the side effects of that or the morbidity associated with that is not worse than the disease itself. And I think you have to balance that, whether it's gamma secretase or any of the other therapies. It really comes down to, well, what is the side effect profile of this drug? How does that going to be best fit for this patient? If it turns out that this is the right drug for the right patient, is how I am thinking about it.
It will certainly become one other drug in our armamentarium for managing desmoid tumors. And according to the safety profile we have been able to see so far, it looked pretty favorable, pretty promising. So I think it's too early to say whether gamma secretase inhibitors will become the standard primary approach to the disease, because even if it will be the only approved drug, we have been using for many years drugs that were not approved for the disease, and they will still be there. So it will certainly be considered in the earlier lines rather than in the later ones.
Absolutely.
And this will certainly happen because of its safety profile. But whether this is going to be or will be the first treatment in case of for patients who fail active surveillance, I don't know.
Yeah.
Again, I think probably today my guess is that the most important competitor of gamma secretase inhibitors will not be other TKIs or medical therapies, but probably the local regional treatments. So the first approach to a patient who fail active surveillance will still be an attempt to try a local therapy, which is not surgery, but then, of course, when patient fails local therapy and a medical therapy is needed, gamma secretase inhibitors will probably be the first to consider.
I mean,
but
I think,
it depends also on the age of the patient,
right.
the gender, of course, right. What they want to have, and so on.
I mean, I would say there is a paucity of data in terms of local regional therapy, such as cryotherapy or chemoembolization. I think we really need a lot more
we do.
Data published on that before we, But I think what will happen is if these gamma secretase inhibitors get an approval, they will be front and center of any conversation whenever we talk about systemic therapies. I mean, I think that it's as simple as that.
There is another question going a bit into the same direction about sequencing of systemic therapies. Do we have already a sequence of for the systemic therapies. At least as we can tell from our recommendations from the Desmoid Tumor Working Group, what we actually wrote down is that there is, of course, no sequence because we do not have any trials which really compared the different therapies. Maybe the only one was the pazopanib, where there's methotrexate winblastin trial. But what we actually recommend is starting with the less toxic therapies, and then we can initially or we can slowly move up to the more toxic ones. Or do you have any other comments on that?
I think you have to give the right drug to the right patient and the right disease. And a lot of this, again, comes down to balancing adverse events with the benefit.
Yeah, I don't think there is a sequence to recommend at this stage. I think it is very reasonable to start from the less toxic drug to the less toxic treatment to the most toxic one, and when it is needed. It is very unlikely that you really need to use all the treatments you have.
Yes.
Usually, patient may fail one line and then they respond to the second line.
Correct.
Also because this doesn't apply to 100% of the patient you see.
Yes,
of course,
I agree.
there will always be those few outlier, those few unlucky patients that in fact experience progression, keep experiencing progression, whatever you do.
Right.
But on average, most of the patients don't need to receive more than 2 lines of therapies.
Agreed.
Yeah. The other point I would like to raise is that the next one on the slide here is, of course, which is always raised. That was even raised in the presidential session at Desmoid.
Who raised it?
You can guess who raised it. About the optimal duration of the therapies, not only for the gamma secretase inhibitors, but also for the TKIs.
Yeah.
What's your opinion on that? Mirna?
I don't think we have an optimal duration of any of these therapies. I personally, in my own clinic, again, look at improvement in symptoms, but also I personally look at the changes in T2 signal. If a tumor goes from being bright cellular to completely becoming a collagen, I think that's a reasonable time to say, can we take a break and just watch for 3 months, 6 months, and if everything is good, maybe we can say that for that individual patient, that's the optimal duration.
I also agree that there is no one answer to the question. I think that what should be, however, said is that this treatment should not be given indefinitely. Mm-hmm. They should be stopped. And normally what we've been doing in the past with other drugs, like low-dose chemotherapy, was to give these drugs for a year or 2, so a maximum of 2 years. But this was not because we had studies or data to support this. It was just common practice. Also because patients were basically tired to be on chemotherapy. Right. And this is why we stopped, simply because they were tired to be on it. And what we saw is that when patients were receiving at least a year of treatment, the chance of durable disease control was higher. That was the reason for us to continue for at least a year, usually not more than 2 years. Now that these treatments are more manageable and less toxic, the question about the duration remains. Yeah. And I believe that drugs like this, given for a long period of time, may become a little bit more, I wouldn't say easy to give, but a little more difficult to give, I would say. Not. So with some risks that we don't know and we can't anticipate, right, because of the mechanism of action they have that was never studied on the long run. So right. I would try to avoid to run into this risk by limiting the duration of treatment to some 1 to 2 years. Of course, if possible, guided by the evidence of the effect. It's a fact that sometimes the effect goes on even when you stop the treatment. Yeah. So you may stop the treatment when the disease is not yet completely turned to inactive, but then it happens later on. Yeah. So this may not be the real sign for stopping the treatment.
Agreed.
Okay, I would like to use the last couple of minutes. We have about 5 minutes to go. And so we should certainly talk about the toxicity profile of the gamma secretase inhibitor, which is more or less the case for both of them. And of course, we should also mention the ovarian dysfunction. And what's your approach with that in the clinic? How do you deal with that with your patients, Myrna? Or with the study patients?
Yeah, no, I think the ovarian dysfunction was a side effect that we had not seen in the phase 1 and the phase 2 study. So this had come up, and I think appropriately, guardrails were put in place to further monitor these patients. In terms of what are the long-term toxic profile, I think we don't know that, right? I mean, the number of patients we have are small, and I think as time marches on and as more and more patients go into these studies, we will learn more about what are the long-term toxicities. At least so far, what the data that we've seen in DeFi seems reassuring. But we have to take that with a grain of salt and say, this is a small number of patients, but we really need a bigger sample size. And as we look at in different geographies and different places, different age groups, how this plays out. But clearly, I think everybody now will be evaluating this, and we'll know in the coming years.
And I think this is one more reason to consider a limited duration of treatment. So, I mean, to limit the treatment to somewhere.
Yeah.
Because this will certainly reduce the risk of having long-term side effects and or impairing the ovarian function permanently.
Mm-hmm.
There is a very practical question from the audience also regarding the side effects of gamma secretase inhibitors. Are there any unique challenges for integrating them into the clinic for the nurses, for other members of the care team? Can you think of anything about that?
I don't think anything more than what we deal with any of the other drugs. I mean, I think there is nothing...
Even less so.
I mean, I think this is I think what really distinguishes this from many of the other drugs is that these drugs have very nice toxicity or side effect profile. So I think,
The only thing I would maybe highlight is the diarrhea, which is actually something where I at least saw in a lot of my patients. Which is usually quite manageable, but something to
agree.
take care of.
Yeah, I think even holding the drug for a few days, giving other things like Imodium and things like that, really we can mitigate much of these GI side effects with supportive care.
I think it's important to mention that these drugs can really be given with a personalized schedule, much more than other drugs.
100% agree.
You can modify a little bit the dose. You can actually interrupt it for some few days
Yes.
without compromising their effect.
I agree.
Okay, thank you very much. I think we can come to the end of this session. I would like to thank especially my two speakers here for their excellent presentations. I would like to thank you for your interest in our session here, in our educational session. I think we learned a lot about the gamma secretase inhibitors, about their possible implication in the treatment of desmoid tumors. We will certainly hear more about them, I'm sure. And thanks a lot for coming. Have a good rest of the CTOS conference. It was nice to have you here. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JST860. This activity is supported by an independent medical education grant from SpringWorks Therapeutics Incorporated.